Okay, I think we're going to get started with the afternoon session. This is the part of the retreat that we reserve every year to bring you updates on core activities and working groups. And again, I mentioned it earlier in the introduction that Mika last year at this event brought us up to speed on his working group, and the newest sanctioned working group is the HIV and Aging working group. So we've asked Mehri McKellar to give us a brief update. Mehri?
Okay, good afternoon. Thank you for being here and inviting me. I'm an infectious disease doctor in Clinic 1K, and I see lots of patients there. And then I also do clinical research, and my new focus has been on HIV and aging. And so I'm going to talk to you about our scientific working group. And as you may recall, last year, Dr. Weinhold mentioned that there's a new push from national CFARs to develop working groups. And I think it's just in the interest of like our economy, and just it makes sense for people who are working on the same subject to get together and collaborate. And we've been encouraged, or CFARs nationwide have been encouraged to find their strengths and develop working groups. And so the HIV and Aging Scientific Working Group was established last year, and I'm going to tell you a little bit about it. But before I go into it, my update, I just wanted to share with you just a little bit about HIV and aging. And Dr. Schmader from the Division of Geriatrics, he's actually going to be talking later today. I imagine he'll also talk a little bit about this. But this has become a really hot topic. Actually, this was a very interesting piece in the New York Magazine a couple years ago talking about HIV and aging. And really, among patients and healthcare providers, there's this concern there's a premature aging process happening. Whether it's premature or accelerated, it's not quite clear. But patients, even patients who are successful on therapy, are coming in and saying that I feel older than I feel like I should, or my friends are. And providers are also concerned about it. And so just as a side note, this has become such a area of interest in the International AIDS Conference. I've been kind of tracking it about maybe 4 or 5 years ago. There were only a couple of posters on HIV and aging. And the last International AIDS Conference I went to, I actually could not even get into the satellite room. They had a seminar on it. It was overspilled into the satellite room, and I sat on a floor looking at a screen because there were so many hundreds of people there to learn about HIV and aging. So, and these are the statistics. So, not only are we having people complain to us, but we're just seeing more older people. And you can see the trend here is increased, and they say by 2015, and actually I've heard now it's corrected to the end of 2014, that 50% of people in the United States will be 50 or older. In San Francisco, already the majority of people are over the age of 50. And in our clinic, actually, this is most recent number, September, we have about 1,900 patients in our clinic, and we have about 43% are 50 and older. So we're almost there. So I get asked this question a lot. Is it this increase in older patients, is it because older people are getting this disease, or is it because they're living longer? And I actually think it's sort of multifactorial. People are living longer, and I'm sure many of you know this already. The drugs have become awesome. We're usually using 1 pill a day. We actually now have 3 single tablet regimens that we're using. So the majority of our patients take only 1 pill a day, which is great, and has made it very easy for patients, including the older patients. And the other reason why people are living longer is now everyone gets put on treatment. You may or may not know that in the recommendations now in the United States, and actually in the Europe guidelines, international AIDS guidelines, is everyone should be on treatment, no matter what their CD4 count is, and no matter what their age. One thing to note of that's the CD4 count, we have seen that there's a little bit of a blunted response when you're older. But in contrast, old people, and I am hesitant to say 50 and up, using the word old, but older people are great medicine takers. So actually we see undetectable viral loads commonly among this group of patients. The life expectancy has increased, including among our older persons, and this is a well-cited study where they looked at longevity or age, life expectancy, and this is actually, so basically the bottom line of this, for someone that comes in your clinic newly diagnosed at age 25, you can tell them that if they take their medicine and do what they're told to do, they will have a normal life expectancy. And what's really interesting, actually, there's some data coming out about older people. They actually think that life expectancy in older patients could actually exceed their peers, meaning older HIV negative patients. So that's kind of curious. And it's probably got something to do that these folks are coming into clinic on a regular basis, and we're catching hyperlipidemia, hypertension, and we're trying to be good primary care providers. So that's kind of an interesting thought. So, and then the other part of increased rates of older patients is indeed new diagnoses, and whether this has become we're getting the baby boomers now are growing up, or it's vitamin V, which is Viagra. We've seen increased rates as well. But it does account now for 17% of new diagnoses. So the reason why I'm actually here is to talk about the working group. And again, this is part of this national response to make HIV and aging a research priority. We established it in September of last year. We're a member actually of a national HIV and aging inter-CFAR working group. And there have been 2 meetings held to date. One of the big things, I think, is that we've been collaborating a lot with the Division of Geriatrics, and I think that's a really important part of it. The Division of Geriatrics actually has a bi-monthly meeting called the DIWG meeting. And now we have representation at that meeting as well. And so I think that has proven to have developed many collaborations. And just so you know, in terms of the members, I don't have them listed here. This is not a secret society. You are more than welcome. If you do have an interest in HIV and aging, please come and approach me. I'm happy to invite you to one of the meetings that is upcoming. So to date, I'm just going to start with the funding, which gets everyone excited, the funding and the grants. Last year, also at this meeting, Dr. Weinhold announced an RFA. It was a Duke joint CFAR and Department of Medicine RFA, and it was awarded in January. And one of them was to study physical function and the role of metabolomics in HIV and aging. And you might have actually seen a poster out there by Audrey Lan, who's the research assistant working with us, looking at physical function in older patients. And we've actually found that it is diminished. Even patients who are stable on therapy don't have the same level of physical functioning compared to normal reference ranges. And then the other award was to Dr. Nagy, who is looking at liver tissue in older patients with HIV. There is going to be a second RFA announced, I think maybe even today, on the same subject. So I encourage all of you, if you're interested in this, to think about it and apply. Other things that have happened is we submitted an R13 conference grant proposal to conduct 3 annual conferences on HIV and aging, and the title is From the Mitochondria to the Metropolis. And this is in conjunction with Emory and University of Miami, and I heard we got a great score, and so we're waiting to hear about the funding later this month. And if it does actually happen, Duke will host year 2, which would be in 2015. So if it does happen, and fingers crossed, I might be emailing you to get you involved, because our focus will be on the focus for that year will be on biology and biomarkers. And again, it will be hosted here. The other grant that came through is the Pepper Center, and again, Dr. Schmader is going to talk a little bit about the Pepper Center. It's the full name is the Claude D. Pepper Older Persons Independence Center, and it's through the Division of Geriatrics. And they actually were successful with their competing renewal of a P30 grant, and they now have funding, sorry, that's my pager, funding for 1 junior faculty, sorry, okay, feel free to answer it actually. 1 junior faculty to work on HIV and aging research. And then one more grant I heard about, that CFAR group, which is a national coalition of the working groups. They actually recently got an R24 to fund future pilots. So there's going to be lots of room for grants and projects and funding. So some ongoing research projects that are happening right now, and I'm not going to go deep into all of them, but I can just give you a one-liner on projects. There's some work being done on metabolomics of HIV and aging and looking at a metabolite profile for our patients, and this is conducted by Dr. James Bain in the Stedman Center. There's interest in looking at inflammatory markers and bone biomarkers. There is a higher rate of osteopenia in our patients, in older patients, and Dr. Krause is interested in this. The third one is looking at mitochondrial toxicity, because that's been a big issue. What I have seen in looking at our cohort, older patients are on older medications or have been on older medications. And a lot of the older medicines, as you probably already know, have the mitochondrial toxicities associated with it. And so we're going to be looking at ART-related mitochondrial toxicity in skeletal muscle in our patients, especially those who've had the diminished performance, physical performance. And then lastly, I think Dr. Lance Okeke talked about cardiovascular disease, and I know that he's looking at the older persons as well. So just as to conclude here, HIV research, I think, is complicated enough in that, and care, I should say, in that we have multiple drugs that these patients are on, polypharmacies, there's a lot of other infections that they can have, socioeconomic and lifestyle issues. And then you throw into aging for these folks, and things get really complicated for the patient and the provider and probably the researcher. Just to kind of get you excited here, there's lots of different diseases that have been, they've shown increased rates of in our older HIV-infected patients: cardiovascular diseases, cancers, bone fractures, liver disease, kidney disease, metabolic complications, cognitive decline, and pneumonia, et cetera. So there's lots of room for research here and lots of opportunities, as hopefully I've alluded to. So I encourage you all to think about if something that you're working on would have something to do with HIV and aging. We have established a cohort now, and I can easily get you linked up with the patients in our clinic or get you linked up with another researcher if you do have an interest in it. One of the things that is still not clear to anyone is that this aging process, first of all, is it real? Are our patients aging more quickly? And if so, is it premature? Or is it just accentuated is the word I wanted to use. And this is actually the best slide because it is quite complicated to put it all together. And this is by a woman up in Yale who does a lot of work on this. Amy Justice is her name. So anyway, I thought it was it's a good overview. And so you have HIV, oftentimes you have viral hepatitis, and then of course some of the lifestyle issues that can attribute to premature aging. And then you have the interacting pathophysiologic processes such as immune dysfunction, microbial translocation, chronic inflammation with HIV, even suppressed HIV, the treatment toxicity like I was talking about with those older drugs, but even the newer NRTIs too have some mitochondrial issues, oxidative stress, associated comorbidity issues, and you put those all together and you'll see an incremental depletion in the organ system reserve, which in the geriatrics world they call frailty. And in turn, you'll see decline, cognitive and functional decline. That's actually another research avenue here that I think we would be really strong at, is looking at cognitive decline, because we definitely see it in our clinic. And that's actually, out of all the complaints, I think the cognitive decline complaint is probably the most common. Organ system failure, repeated hospitalizations, nursing home placements, and then ultimately death. So anyway, thank you very much. That's the end of it. Questions or anything?